Okay, thank you very much for a kind introduction for me, and it is a great honor to be here. My talk is a selective surgical management of main duct IPM, especially pure main duct IPMN. So today's topics is one is characteristics of the pure main duct IPMN without any dilatation of the branch type IPM, and the fact is indication of surgical resection, and also what are the factors associated with invasive main duct type IPML. And finally, I'd like to talk the recurrence pattern after surgical resection. So this is a IAP guideline in 2017. What is the definition of a main duct MD type IPMN? It's a MD main duct IPMN is characterized by the segmental or diffuse dilatation of the MPD of more than 5 millimeter without other cause of the obstruction. And this is a guideline for European IPM guideline, and this guideline shows that few studies have investigated a mixed type IPMN as a single entity. So malignancy rate appears similar of mixed type and main duct IPMN. That is means almost all studies of main duct IPMN included mixed type IPMN because of the small number of pure main duct IPMN. And what's the characteristics of mixed type and also main duct type? The left figure means pure main duct type IPMN, and the right side is, of course, mixed type. And we compare the characteristics of pure mixed type IPMN and with those of mixed or branch type IPMN here. So we have rejected 334 patients with IPMN for during 20 years in my university. Among them, the 68 patients had a pure main duct IPMN. It's the dilatation of the main duct more than 5 millimeter and without dilatation on the branch duct type. And it's 68 patients, it's 20%. And the influence frequency of the high-grade dysplasia invasive IPMC, it was 69.1% here. And this value is a lower incidence of the GD invasive IPMC in mixed type 1, but the higher incidence compared to the branch type IPMN. And what about the invasive IPMC frequency? The frequency was 36.8. This one, and this is almost similar to the mixed type and mixed type IPMN, and higher instance compared to the branch type IPMN. And what is the characteristics of pure main duct IPMN? As you can see, the incidence of pancreatitis, the incidence was 27%, and compared to the mixed or branch type, the incidence of pancreatitis was higher compared to the other subtypes. And also, what is the location? So patient with main duct type for pancreas was 29%, and the dilatation of main duct was wider compared to the other types. And also, we have focused the CEA level in the pancreatic juice, which was taken by the preoperative ERCP. The value of the CEA in the pancreatic juice was higher. And also cytology is, of course, class 4 and 5. These are the characteristics of main duct type IPMN. So the summary is the pure main duct type IPMN had more frequently pancreatitis, diffuse region in the forward pancreas, and the positive cytology in the pancreatic juice compared to mixed type IPMN. This is a paper from Germany. And what is the indication of surgical resection for main duct type IPMN? This paper clearly shows that even the size of the main duct, 5 to 9 millimeter, the incidence of high-grade dysplasia and invasive IPMC, it's almost 60%. Then main pancreatic duct dilatation, 5 to 9 millimeter, become one of the worrisome features in the IAP guidelines. But however, this study also includes the mixed type IPMN as well as pure main duct IPMN. And what factors associated with HGD invasive IPMC for pure main duct type IPMN? And this is a predictor of HD high-grade dysplasia invasive IPMC for pure main duct IPMN. As you can see, this is a univariate analysis. As you can see, we have found the three predictors. One is main pancreatic duct size and mural nodule size, and also CA level in the pancreatic juice, which was taken by the preoperative ERCP. And also by the multivariate analysis, only the factor of a mural nodule more than 4 millimeter was independent risk factor for high-grade dysplasia and also invasive IPMN, like this. And survival for main duct type IPMN, we compare the non-invasive type or invasive type. The left figure shows the overall survival, and right figure means recurrence-free survival. As you can see, of course, the survival in the patient with non-invasive IPMN was better than the invasive IPMC. And next topics is the factors associated with invasive pure main duct IPMN. And as you can see, we have found the two independent risk factors for invasive IPMC. One is a mural nodule, and another one is a CEA level in the pancreatic juice, two factors. And next, we calculate the cutoff level by ROC. And the left figure is the mural nodule size, and the right side is the CEA level in the pancreatic juice. And we have found the cutoff levels are mural nodule size more than 6 millimeter, and the CEA level in the pancreatic juice, which was taken by the preoperative ERCP, is a 300 nanogram. And this is the diagnostic value of invasive pure main duct IPMC. So as you can see, when we apply the only mural nodule size more than 6 millimeter, the accuracy was 81%. And when we combine the two parameters, mural nodule and the CA level, the accuracy was 84.1%. So measurement of mural nodule size and the CA level of the pancreatic juice might be useful for diagnosis of invasive pure main duct IPMN. And what is the surgical treatment procedure for mixed type IPMN? Usually, the total pancreatectomy is well adapted for this entity, but this paper clearly shows that among 93 patients undergoing total pancreatectomy, this one, 10 patients, it's a 12% had a misdiagnosis of main duct involvement of IPMN. So our question is total pancreatectomy necessary for pure main duct type IPMN? And this is our data. Left side is overall survival. We compare the survival of the patient with partial pancreatectomy to total pancreatectomy. As you can see, so no difference between two groups. So maybe we have to say, so total pancreatectomy could not improve the overall survival and the recurrence-free survival of main duct type IPMN. I would like to show you one representative case. This case, as you can see, the main pancreatic duct was dilated 16 millimeter, and the mural nodule size is 14 millimeter, and the C level in the pancreatic juice 432 nanogram per ml, and the cytology was class 2. And we decided to perform the pylorus resecting FIPRO operation, and histology was invasive IPMC T1A N0 stage 1. And almost 4 years after surgery, as you can see, that we found the recurrent tumor in the remnant pancreas, and the main duct dilatation was at 9.3, and the mural nodule was 6 millimeter. And we decided to resect the remnant pancreas, and histology was invasive IPMC and the T1A in stage 1. And very fortunately, this patient alive without recurrence for almost 8 years. And we have experienced such cases. So this paper is our data. So when we found the recurrent tumor in the remnant pancreas, and after we resect the remnant pancreas, the survival is very good. And the second operation for remnant pancreatic recurrence might improve the survival. So total pancreatectomy might not be always necessary, even the IPMC patient with low-grade dysplasia of the surgical margin after the partial pancreatectomy. So this is the final slide of my talk. So main duct type IPMN might have the specific characteristic different from the mixed type IPMN. So mural nodule more than 4 millimeter was only independent factor associated with high-grade dysplasia, invasive IPMC for main duct IPMN. And measurement of mural nodule size and the CE level in the pancreatic juice, which was taken by the preoperative ERCP, might be useful for prediction of invasive main duct IPMN. So total pancreatic